Hello, everyone. I'm Dr. Meltem Zeytinoglu, Dr. Zay. I'm very pleased to join you again with another colleague of mine from the University of Chicago Kovler Diabetes Center. I'm welcoming Dr. Raghu Mirmira today. Dr. Mirmira is a professor of medicine at the University of Chicago and director for the Center of Translational Research. He's also the an editor-in-chief of the Journal of Clinical Endocrinology and Metabolism, and we're very happy to welcome you and your expertise today. How are you doing today, Dr. Mirmira?
Doing great. Delighted to be here. Thank you so much.
Thank you for joining us and bringing your knowledge with us. I think your role as sort of at the leadership of translational medicine is important as ever. It always is, but we're learning, so the scientists in us and around the world are sort of at the forefront of this, and how we take care of our patients with this novel virus. And so, one of the things that we've been hearing so much about with the pathologic aspects of this is the inflammatory response. And as diabetologists, and unfortunately seeing that some of the patients with more difficult outcomes in this are our patients with diabetes, what are you learning about inflammation and the response that happens particularly in our patients with diabetes?
Yeah, that's a great question, Meltem. My research over the years has focused a lot on the idea that inflammation is not just an aggravating factor for diabetes, but sometimes can be an initiating factor. And so inflammation occurs because when you get sick, or when you have obesity, or you even have type 1 diabetes, various cells around the body secrete what we call cytokines. Mm-hmm. And that's a fancy term for mediators of inflammation. And sometimes these cytokines are local, meaning they just affect the cells that surround where they're secreted. But many times these are affecting the whole body. Mm-hmm. And COVID-19 is a good example of a situation where when you get sick, it's multiple organ systems. And what we're learning now is that not just people with diabetes, but everybody has elevated levels of these cytokines that are circulating in the bloodstream. And as you can imagine, because there's elevated levels, these things begin to affect multiple organ systems. So particularly the organ systems that are known to affect diabetes. So what we are learning is that if you had diabetes before getting COVID, then your chances of dealing with the infection are a little bit worse than the person without diabetes, because you've already got cells that have been affected by diabetes. Now they're getting affected even more by these cytokines. And if you didn't have diabetes, or you didn't know you had diabetes, or you had pre-diabetes, sometimes having an infection like COVID will bring the disease out because of these cytokines. And they can affect insulin production, but also the way insulin acts. And that's what we're learning now. And that's why there's a lot of talk about inflammation.
That's very helpful. And that's interesting. I'm really glad that you brought up sort of, accelerating the disease process. One of the things that I've been trying to reassure some of my patients, we talk a lot about how, as of now, we don't think that just having the disease itself is a risk for contracting the infection. Rather, as you said, once you have it, having more severe complications potentially. But I think deep down, some of us are wondering, are those of our patients who have more uncontrolled disease, where they're already in a pro-inflammatory state, could that predispose them not only to either contracting, but especially having that accelerated risk? Have you noticed any literature or any anecdotal data from your colleagues where patients who are more uncontrolled and already have that inflammatory state are having an accelerated response?
Yeah, so that's really a great question as well. So when we say that diabetes doesn't necessarily increase your risk of contracting the disease, we say that with caution, in large part because we want to say that when we have the data to back it up. And
Yes.
right now, we're still accumulating that data. So it may turn out that we'll learn one way or the other down the road. But let's be clear about one thing when it comes to diabetes, and that is that uncontrolled diabetes leads not only to a high blood sugar, but also leads to dysregulation of other aspects of metabolism. So sometimes your fat levels can go up in the blood, and then certainly when fat and blood sugar rise, so do your cytokine levels rise. And what we've been learning, for example, is that when all of this happens, it can affect how the immune cells normally respond. Mm-hmm. So we know, for example, that poor control of diabetes can lead to what we call microvascular disease, diseases of the small vessels that affect organs like the kidney, and the nerves and the eyes, and that's all because the immune cells that are important in protecting these various different organs now don't function normally. And so if you then extrapolate that information to risk factors for other intercurrent diseases, one can imagine a scenario where poor control of diabetes could actually suppress your normal immune response and therefore put you at risk for other diseases. All of that said, we just don't have enough evidence right now to be able to say that's true for COVID-19. And I think ultimately, while a lot of that work that I've talked about has been done, in sort of the experimental laboratory, all of this stuff has to be verified in the real world with patients to find out what patients are actually experiencing.
I want to talk a little bit more about how we can translate this science into patient care, and we're already doing that. We've got clinical trials underway. You talked about these molecules, the cytokines. So how can we target those in a way to try to suppress some of this inflammation in COVID infection?
So it's kind of exciting because a lot of companies have developed molecules or antibodies that specifically target these cytokines. And we've used these kinds of drugs in various diseases that are marked by inflammation. And in fact, we've even done this in the setting of diabetes. So one of the cytokines, there's one called IL-1 beta, which is also a cytokine that appears to be elevated in COVID. We actually have developed many years ago a molecule that blocks that. And it was shown when that molecule was given to people with type 2 diabetes, their blood sugars improved. Their disease got better. Their insulin-producing cells functioned better. And so that was evidence, and that was a paper published in the New England Journal of Medicine many years ago. But it was really very strong evidence that if we then take these cytokines and know which ones are elevated in disease, and then we can develop therapeutics against them, that can actually make a big difference. In the setting of COVID, as you can imagine now, we know that some of these cytokines are elevated, and there are already clinical trials ongoing right now. One is against another cytokine called IL-6, for example. That are being tested to see if targeting those can reduce inflammation. And importantly, a paper was published within the last week or so that showed that, for example, people with diabetes have higher levels of IL-6 compared to those who don't have diabetes but have COVID. So, that again is more evidence that diabetes itself can worsen a disease process, and then targeting these cytokines with drugs could maybe make a difference. We just have to see.
Absolutely. And so I think for this is for the doctors and the scientists watching, this is all very exciting. What I think is really wonderful for our patients is seeing how we're bouncing back from the lab to how this translates into patient care. So I want to go back to the lab for a moment now. And you mentioned how diabetes affects other metabolic processes too. And so one of the things that we commonly that we see associated is fat metabolism and how that is affected. And so we're seeing some different patterns in diabetes. You know, when there's not enough insulin, we sometimes see this phenomenon of ketoacidosis, and that typically occurs when sugars are a little bit more elevated. What are you learning, and what have you been seeing? How is that process occurring in patients with COVID infection from what we know?
That's very, very interesting. So, you know, the one thing about insulin is that when you don't have enough of it around, the body then imagines that you don't have enough fuel. And so what it will do is start producing all kinds of other molecules that provide fuel primarily to keep the heart going. And one of these are ketoacids. So we often associate ketoacidosis with high blood sugars, but it really is more associated with having enough insulin around. So, you know, you can imagine scenarios where you don't have enough insulin, but you don't eat a lot. And so your blood sugars don't rise very much. And maybe you don't have enough fuel stored up in the liver, for example, where the liver can produce a lot of glucose. So as a result, not having you know, enough glucose in the system and then having not enough insulin can actually produce ketoacidosis without high blood sugars. And so we're seeing some of that happening with COVID. And it could be because you know, the kidneys are getting rid of a lot of the sugar, or it could be because the body isn't producing enough sugar, or that people who come into the hospital just haven't been eating. They've been very nauseated, throwing up a lot. And their blood sugars may not be that high, but their insulin levels are very, very low because they, you know, have a defect in insulin production when you have diabetes, regardless of the kind. So the risk of what we call normoglycemic ketoacidosis goes up. And we've been seeing that anecdotally, certainly.
And one of the tricky things is the overlap in symptoms, right? That can often be associated with nausea and abdominal pain. And we know that gastrointestinal symptoms are, you know, we commonly think of coronaviruses with more upper respiratory, but this one, COVID-19, is showing us some lower. So we're telling our patients, you know, this is where when you're feeling sick, be in touch with us. We'll tell you about ketone strips and ketone monitoring. So that's really helpful. Thank you. Let's shift a little bit to another patient area, but you know, it affects some of our patients with diabetes, but a lot more broadly too, patients on steroids. This has been a really important topic. There was some initial data that showed that, you know, the virus may be, the respiratory symptoms may be worsened by high steroid exposure. And we've learned a lot more since then, but of course there's been a lot of debate now. What should we do about our patients on oral steroids? Even patients are worrying now about inhaled and nasal steroids, and we've got a lot more data and guidance now for those. Can you tell us a little bit more about that?
Definitely. So, you know, steroids are often given in different diseases, particularly very inflammatory diseases. And sometimes we give them for short periods of time, sometimes we give them for very long periods of time. And it's not unreasonable to think that when you have inflammation like you have with, you know, COVID, that maybe steroids could be helpful. Our experience with the prior infections such as SARS and MERS showed that if you just gave steroids for that disease alone, there was either no benefit or it made the situation worse. So that's important to know because we don't want to give steroids to people who just have the infection. We don't think that there's any benefit. The World Health Organization recommends against that. However, there are people that are taking steroids chronically for other inflammatory diseases. You know, they might have various forms of arthritis, you know, lupus, other autoimmune diseases. Some people might be, you know, taking these steroids because of severe allergic reactions, like, you know, severe asthma or other allergic reactions. So these are individuals that, we have to be very careful about. The first thing we need to know about them is that they're on steroids for a good reason. They have an underlying disease and they need those steroids. So they shouldn't stop them out of fear that it could make their COVID worse, because that could also make their other diseases worse. But we need to recognize that when you're on a high dose of steroids for a long period of time, your own body doesn't have the ability to make adjustments to its own production of these molecules, which it normally would have to. And so as clinicians, we're the ones that have to make the appropriate adjustments to these doses. Mm-hmm. And so when people are taking long-term steroids for any number of reasons, now is not the time to stop it. If they get ill, we probably do need to increase the dose of them a little bit, because that's how they're going to cope with stress. Mm-hmm. And stopping the steroids are probably going to make the situation much, much worse. So that's the first thing. The second thing is that there are some people who don't have normal adrenal gland function, and those people are people, and the adrenal gland, I should say, is what makes these steroids, right? And so we put those people on what we call physiologic doses of steroids. So they're not on high doses. So we don't think that at the doses of steroids we're giving them, they're at any greater risk of contracting any kind of disease. They're just getting the dose that they need, that their body would normally produce. And again, these are people we have to be very watchful of, because when they get sick, they'll need more of that. Not a lot more, but they'll need more. And so, most people who are taking these steroids, their physicians give them sick day rules. Mm-hmm. And it's critical that patients follow those sick day rules. And if they get sick, obviously follow the rules and then call your physician. Mm-hmm. Because steroids are not an easy thing to manage in the context of COVID, but in all likelihood, people who are on them will need those steroids managed, probably at slightly higher doses.
Okay. And so that's a really helpful point. I think one of the bright things that we are all learning, we've been trying to highlight those in these videos. There are many bright spots, and one of the reminders is, we see patients and we have 15 minutes to see them sometimes, and we have to go through their blood sugars, their blood pressures, and so many other things. And we try to take stock of everything, but this is a reminder that steroids are necessary, but we as the doctors should also be trying to make sure that we're never using more than we need to be, and that we're taking stock each time. Does the patient truly need to be on it? Can we be trying to wean them off? From the patient's end, it's also a reminder not to get overwhelmed by the sensationalization of some stories. The news gets excited and they're just trying to report what's new. But that's where individualization is so important, because what they tell you on the news that it doesn't help is not intended for you individually as the patient. And you may have, as Dr. Mirmira is saying, much more harm by not taking it individually. So thank you for explaining that. Let's now shift as we wrap up into your role more as a leader of the Translational Medicine Center, and then also at the JCEM. Let's talk a little bit about what our colleagues in the labs and running clinical trials and those of us seeing patients, how as scientists can we be moving forward and trying to put this data together? What should we be doing going forward?
That's another great question. So let me wear my editor hat for a moment for the journal. One of the things that we've been noticing in the journal, particularly now, is that a lot of people have opinions, points of view, and sometimes data related to COVID, and feel the need now to bring it out. And the problem is that in a time like this, while everybody wants more information, science has to be done and vetted the way it always has been done. And sometimes what that means is that it's going to take a little bit more time to get that information. Mm-hmm. So we've been very careful about what we publish in the journal and make sure that it's not published too soon.
Yes.
And that's the worst thing that can happen is data that get put out there get misinterpreted and then completely change our practice when it shouldn't. So that's the first thing as a journal editor that I say, is that we are very watchful of, of how that data looks and how it's interpreted. But for those of us in the lab, this is a difficult time for us because, we've never really been equipped to study viral infections. And so we're not in a position right now where we can shift our research from whatever it is in the area of diabetes to studying how COVID affects our disease. So, what many of us are doing is we're still forging ahead with the research that we originally did. I mean, we're still trying to understand why diabetes occurs, why diabetes puts you at greater risk when you have other diseases, not just COVID. Because sooner or later, we're going to get past COVID, and the important questions will remain.
Yes.
Diabetes is one of the most prevalent diseases in our society. It puts us at risk, not just for COVID, but for many other diseases, and it could make other diseases, worse when you have diabetes. And so one of the things that I've been doing in my lab with my lab personnel is getting them to think about the research that they're doing and why it's still very important. Because in the end, everything that we learn is going to be applicable not just to COVID, but to all other diseases in which people with diabetes experience. And that's going to be a pretty sizable percentage of our population. So we're working right now on ensuring that we're writing up our data and our papers, that it gives us a little bit more time to read the literature a bit more and be a little bit more scrutinizing of our own data. So we're still proceeding, and we're still expecting that when this is passed, that we'll continue to get back in the lab and continue to fight diabetes.
Absolutely wonderful. I think that's for our patients who were suffering before this and will continue to thrive while enduring their diabetes. They're really grateful to hear that this is continuing to go on, and this is an opportunity to hypothesize, to as you said, pause and be thinking about the future and what other questions you can be asking. And so we thank you for continuing this work, and for being a bridge between so many different places, between the lab, the patients, the journal, and we all really appreciate the expertise and your time today. Any comments to wrap up with for our audience?
So the only comment that I make, as I always make, is that as researchers, we fight on. We focus on the disease that we're so passionate about. In my case, it's diabetes, and so if I can assure your viewers of anything, and that is that we continue to fight for that disease, and whether it's in the setting of COVID or any other disease, diabetes remains our top priority.
Absolutely. Thank you so much. Please stay strong, stay healthy, and we will endure and thrive, as we said. Thank you so much.
Thank you so much. Take care.